welcome once again to yet another Ankota Healthcare Delivery Management webinar. This is our Care Transitions Best Practice webinar, and we do it every month, as I'll go over in a little bit. I want to welcome you one and all. I see that we have some familiar names and some new names, so that's exciting. Tim Rowan, as you probably all know, but just in case you don't, he is the editor and principal writer of Home Care Technology Report. He's been doing that since 1999. Prior to that, he was the IT director of a 5-branch home care agency in Colorado, which he did for 5 years. So, to my mind, he is, the guy in home care IT.
Thanks very much, Jed. Good morning, everyone. I'm coming to you from my office in Colorado Springs. So thank you for the people on the East Coast for giving up your lunch hour for this. I'm hoping that we can cover some things today that are going to be useful and practical and valuable for you. I've titled it Thriving Through Healthcare Reform, because I think that's the issue that's on everyone's mind today. Healthcare reform is changing everything. Nobody's quite certain about what things are going to be like 2, 3, 4 years down the road. I have some thoughts and some predictions. Only time will tell how accurate I am. But I'd be very interested in your feedback after you hear the background and exactly how I'm going to walk through this. So, see if we can move on. For some reason, this is working great yesterday, Jed. My screen does not want to go. Okay, are you ready? Let's start with the background, the required content for every presentation, a little bit of the demographics that are going on. Of course, as you know, 76 million of us baby boomers are turning 68 this year. Even the youngest are now 50. Everyone is concerned about the Medicare Trust Fund running out. I think the current prediction is the year 2033. We're watching accountable care organizations forming. 120, 130 every January are being approved by CMS. And that's going to have a major impact on the way home care does its job. And everybody is concerned about some new payment system that's coming in. Nobody's quite sure what it's going to look like. What we know is that physicians and hospitals are no longer going to be paid for multiplying services. It's going to be more pay for patient outcomes. So, whether that will be a bundled payment system, a shared savings system, there are a lot of demonstrations going on. We have to watch it to see which one of those payment systems is going to win and which one is going to move its way into home care. And probably the most important message is healthcare reform is here to stay. I'll spend a minute explaining why I believe that. It doesn't matter anymore who controls Congress and who's in the White House. Healthcare reform is here to stay. Let me give you one reason why. This paragraph shows you countries around the world. If you look at the 3-letter abbreviations, you can probably identify a lot of these. And the vertical is the life expectancy, and horizontal is the spending per capita. So you look at the very bottom one, for example, India has the lowest life expectancy and the lowest expenditures. You move up to the right, you see Russia. Up above that is Brazil, and all of them are more or less along the continuum. Wait a minute, not everything is showing on the screen here. I don't see the U.S. Let me see if I can adjust the screen. Oh, yeah, there we go. There's the USA. By far the highest per capita health expenditures, but nowhere near the highest life expectancy. So we're not getting what we pay for. This is the reason that I believe healthcare reform is here to stay. Something has to change. Whether it takes the form of the Affordable Care Act in its present configuration or not, we have to all be prepared in home care and hospice for drastic and ongoing change to try to fix this problem. We can no longer tolerate this kind of expense for these kinds of results. And if you look around some of the reports that have been published in the last few years, like this one from the Commonwealth Fund. Even as healthcare spending per capita has increased in the U.S. over the last 3 decades, and it has, spending is on the rise, we're still falling behind in the survival rate for people at ages 45 and people at 65. The 15-year survival rate, we're worse than nations that spend less. The Institutes of Medicine estimates that hospitals are a very dangerous place to go. For example, hospital errors, if the airline industry killed as many people by accident as the hospitals do, you'd have to crash a fully loaded 747 every week. I wouldn't fly if that happened, and I certainly wouldn't go into the hospital if I didn't absolutely have to. And then we look at one of the causes of that, and it's adverse drug effects, drug events. One of the things that I learned just a few years ago is that the fourth leading cause of death in this is the correct use of prescribed medication. The fourth leading cause of death is the correct use of prescribed medication. So we got to do something about the way healthcare is being handled here. One of the things that we're looking at doing is keeping people out of the hospital once they're discharged. Medicare is estimating that could save $12 billion a year if we could get the control. If you're working in home care, keep in mind, this is about you. Who is best at keeping people out of the hospital? Not the hospital discharge planner, not even the primary care physician, but it's the nurse in the home that's best at saving this $12 billion. Question is, does the world know it as they rely on home care? The solution that's being put forth by the Affordable Care Act is to create these accountable care organizations where the physicians themselves become responsible for the keeping people out of the hospital, for patient outcomes. So the importance of the accountable care organizations is going to become more and more important to home care providers as time goes on, and I'm going to talk at length this morning about the importance of you seeking partnerships. What the statement says from Brookings and Dartmouth is exactly describing home care. They're looking for more effective integration. Who's good at that, if not you? Looking at more effective care coordination. Again, hospital discharge planners are not good at that, but home care is. And the more home care gets involved, the more the Affordable Care Act is going to reach its goal. CMS put forward a study that is worth noting as well. I've heard 20% of Medicare patients are readmitted within 30 days. That is way too high, costing $20 billion just for the elderly, just for the Medicare patients of the total hospital costs for preventable hospitalizations, not just readmissions, but preventable hospitalizations. 3/4 of readmissions are avoidable or unnecessary, the CMS study shows. $12 billion, just the same as Dartmouth found, can be saved by reducing avoidable readmissions. And here's the important one. Half of the patients who did bounce to the hospital in 30 days were found to have had no doctor visit. This is another area where home care is needed. One of the things that the home care nurse accomplishes by knowing what's going on intimately in the home is whether they are making and keeping their appointments, and on the side, whether they are filling their prescriptions and actually taking them as well, which is another huge cause of readmissions. So all of these studies keep turning around back to how important home care is in the effort to control costs and improve care. These are the things that accountable care organizations are responsible for. If you look at this list, prevention, coordination, electronic records, proven treatment, day or night access, does that not to you describe what home care is best at? So what I'm promoting and what I'm recommending to you is to seek these partnerships with accountable care organizations as they spring up in your neighborhood, because you are exactly what you need. Every single one of these problems and the mandates that the ACOs are required to fulfill name home health care as the solution. Every single one of these. What my experience has been, though, is that the hospitals and the physicians, they don't think of home care right off the top of the bat. It becomes your responsibility how perfect you are as a solution to the exact problems that they are commissioned to solve. If you think that there is a possibility that the healthcare environment is going to go back to the way it was before the Affordable Care Act, think about these things. Because of the abysmal condition of the cost and the outcomes of the U.S. healthcare system, reform is here to stay. It doesn't matter if the Affordable Care Act is the form that it takes. It's here to stay. And here's part of the stall that we're looking at right now. We have to talk about a political reality. Yes, the Affordable Care Act is nowhere near perfect. It needs to be fixed, but that's not going to happen. Look at the climate, the political climate in Washington. The Democrats understand that the Affordable Care Act can be improved. The Republicans, who will filibuster in the Senate and who control the House of Representatives, are not interested in making those fixes. The House has had 50 bills, 50, actually more now than 50 votes to completely repeal the Affordable Care Act. And they don't do this because they think it's going to happen. They know the president will veto it, so they know it's a futile exercise, but they do it so that they can go back to the voters in their district and say, I voted to repeal Obamacare 50 times. I know this from personal experience. My own congressional district is said to be the safest Republican seat in the country. The election is over with the primary. We haven't had a Democratic congressman here ever. And yet he's campaigning, and in his campaign literature, he brags about having voted against Obamacare 50 times. So in Congress, the Republicans are not going to allow bills that make the fixes that the Affordable Care Act needs. So what's going to happen in November is either the Republicans take over the Senate and keep the House, which won't change anything because the president will still be vetoing any bill that tries to repeal the Affordable Care Act. So we're not looking at any change unless the Republicans take over the House and the Senate and the White House in January of 2017. By that time, the Affordable Care Act will have been in place for 3 to 5 years and will be very difficult to change by the time it's that well embedded. For this reason, I encourage you to assume that healthcare reform, largely in the form of the Affordable Care Act, is going to be part of your life for the rest of your working career. Second thing, economic reality, is that one of the ways in which Congress and CMS think that they're going to save money is by reducing the rate at which they reimburse home care for Medicare, Medicaid. Even the insurance companies are getting on the bandwagon. They don't understand that paying more to home care saves money overall in the long run. And so they're trying to save money by cutting, and they need to be re-educated to understand that what they're doing is counterproductive. But you can count on these pay rate reductions being part of your life for several years until we find a way to re-educate MedPAC and Congress and CMS. And the third reality to do with is that acute care, hospitals, and primary care, the physicians who are the ones forming the accountable care organizations, are in a terrible bind. They have to spend all this money on software so that they can get the bonuses for accomplishing meaningful use. The readmission penalties for the hospitals are up to 3%. They know they can't fix it alone. In order to accomplish meaningful use, in order to qualify for the bonuses, they have to demonstrate that they can exchange patient data with other care centers, including post-acute care. That means they need you. They need to be able to exchange patient data with you in order to get their bonuses. So they need you there. The readmission penalties, they want to get down from the 3% level, so they're not paying the maximum, They're paying a smaller amount. They need your help to reduce readmissions. So you're in a good spot because you're also on top because of the realities of the incredible inflation that we've seen in the number of Medicare home health providers over the years. Only 2 years ago, 3 years ago, there were 11,000 of you. As of December of 2013, there are 12,611. CMS needs to stop this, and they're doing everything they can to reduce the number of agencies. But the important thing to look at is who these agencies are. As of December of last year, two-thirds, 8,000 out of the 12,000 agencies that gross $2 million a year or less. These are tiny agencies. But look at it even more deeply. Half at the end of last year, 6,000 of the 12,000 are agencies that gross $1 million a year or less. These are little mom and pop shops with 4 employees. And these are the ones that CMS is targeting to get rid of by reducing the payment rate. And these are the ones that are going to have an extremely difficult time competing for the attention of the account care organizations. And it's going to be very difficult for them to survive. Don't be surprised if in 3 to 4 years there are 6,000 to 8,000 Medicare agencies, not 12,611. I sincerely believe that CMS does not think that 12,000 is the number that is needed, and they're going to do everything they can to reduce it. So they have figured out a way to reduce those numbers. It's marginally profitable by continuing to reduce your payment rates, and they're going to use the excuse of eliminating waste and fraud to close other agencies. What's happening here, and I'm sure you've seen it, is that the surveyors in the state and the auditors who are federal contractors like the ZPICs and the MACs are using every excuse they can to deny payments. Even if you appeal, it takes forever to get your money back, and many agencies, especially the small ones, can't survive that. They might win the appeal, but they will have had their doors closed a year before that because it's so difficult to operate without cash flow, and it takes so long to appeal these payment denials. So CMS is using these, excuse me, these 2 methods to reduce the total number of agencies. So how are you going to be? Well, let's look at a couple more of the political realities and then talk about that. Some good and bad things going on. There's a lot more Medicaid money because of the Affordable Care Act. You have to live in a state with a Democratic governor because all of the Republican governors have refused that money. It's good things happening because the Justice Department, through its HEAT task force, is getting rid of the fraudsters in our midst. But they only make arrests for the big fraudsters. They're only after the $90 million and up arrests when it makes headlines. Congress has done something to get rid of fraud. By putting in this law about the face-to-face documentation, they're getting a lot of people who don't need home care off the Medicare rolls. But you've got CMS who figured out a way to implement Congress's law by making rules, and they did it in the worst possible. In fact, they attracted a lawsuit from the National Association for Home Care telling them that their rulemaking is stupid and it is counterproductive, reducing beneficiaries' access to care among people who really need it. Another that's happened. The Obama administration is using the Affordable Care Act to reduce fraud and abuse, but they have done it with a bounty system. They're paying commission to the auditors who are looking for fraud and abuse, and they're finding it where there isn't any. You make an honest mistake, and your payment is denied because they are so aggressive, and they are making so much money by getting a percentage of every dollar that they return. So it's making life much more difficult. Consequently, in order to survive, I'm seeing a lot of Medicare agencies looking at getting into Medicaid and private duty. At the same time, under the grass is always greener on the other side of the fence rule, I'm seeing a lot of private duty agencies looking at diversifying by getting into Medicare and Medicaid. Consequently, seeing a lot of Medicaid agencies looking at Medicare and private duty. So everybody thinks there's a way to thrive by looking at the greener on the other side of the fence. So with that environment in mind, what I see happening with the U.S. healthcare system is major change, where every provider has seen him or herself as a silo, self-sufficient. They're going to be forced now to work with each other so that the patient care experience is seamless. Instead of getting paid for services, they're going to be getting fixed payments. The ACOs, for example, will be getting a bundled payment and may or may not share it with home care in order to take care of the patient. Depends on how well you sell them. Instead of volume of services, they're going to get paid for outcomes. And of course, as you know, since 1995, there are more Americans with chronic conditions living into their 80s and 90s than there are with acute conditions. So chronic care is changing the face of home health care. People are less and less reliant on hospitals and more interested in getting care in the community and in the home. Instead of being centered on the hospital system, the Affordable Care Act is pushing the healthcare system to center care around the person. So what all this comes down to is that the entire U.S. healthcare system is being required, is being urged, is being pushed toward improving the patient experience, improving population health in general, and reducing the per capita cost. Once again, the perfect storm for home care to step in and say, hey, we're good at that. We can help you, hospitals and physicians and ACOs, to achieve the triple aim. But there are challenges to you too. You're going to be getting lower reimbursements, and you got to figure out a way to remain profitable. You've got to increase your current market share, even in the face of all these little mom and pops getting in your way. Data is going to become king. You have to collect and learn how to use the data that you have. Remaining in compliance is an issue. Compliance is expensive, but in the long run, it pays you back. And of course, you have the business challenge of finding qualified people to take care of patients. How do you do this? How do you find time when you're worried about payroll this next week? How do you find time to be thinking about 3 years down the road? How do you position and prepare yourself to thrive in the midst of this constant change? One of the things that we can do is look at the areas where we can help foster growth. One of these is the way the feds are going to be pushing you. CMS and Medicare, Medicaid, even insurance companies are loving the model that Kaiser has been putting forth out in California and Colorado. This is basically a combination health plan, hospitals, and medical groups. The care delivery and the payment for the care are all in-house. It's essentially one huge ACO, and the feds kind of like this model. I think that's the model they're going to be pushing on us. And do the best practices. I'll go through this quickly. The best practices that Kaiser has developed over the years. Some of the things that are interesting for you are one physician to deal with who takes care of the patient throughout the post-acute care experience. 24/7 availability of home care services through that primary physician. Look at this one, the number 9, the 2-tiered admission process. They don't allow their emergency department physicians to make an admission decision. They have a dual level to control the admissions, which means very often they're going to bounce a patient from emergency back to home care, and they can coordinate that because they meet weekly or monthly with their post-acute care partners. Watch for these best practices to be imposed on all of the ACOs because the feds seem to love what Kaiser is doing. So we go to a hospital, and tell them how wonderful your home care services are. Keep in mind that you don't want to emphasize too much their readmission penalty, because that's not, they're willing to absorb that as a cost of doing business. But take a look at what it's going to cost them when they're not getting reimbursed for taking care of that readmitted patient. It's going to be twice as much as the penalty. A typical $100 million Medicare hospital, if they get half of their patients back, if they get 500 patients back, this formula that I learned from a home care accountant named Pat Laff demonstrates that these hospitals are looking at a $6 million hit for a patient that is, or for keeping their readmission, for not keeping their readmission under control. This is where hospitals are vulnerable, and this is where you can step in and say, we can help. You need us. You need a partner. So the ACOs have 33 quality metrics that can be summed up by saying they get bonuses if they're more cost efficient, if they provide savings, while they're providing better care and focusing on population health. If these 33 quality metrics result in those three things, the ACOs get bonuses, and they need your help to do that. They learn, too, the post-acute care community, but, and this is a big caveat, they will not contract with all of you. They are looking for efficient, professional, highly effective home care agencies to partner with. They're looking at agencies that can already demonstrate their own low readmission rates, agencies that have active, proactive readmission prevention programs in place. And they're looking for technologically sophisticated home care providers. For example, number one, most important thing that you can be working on right now is your ability to exchange patient data with hospitals and physician groups and ACOs. None of the other technology that you can invest in comes close to comparing with this as importance. Do you know what your software is capable of with regard to exchanging data, patient data, with outside groups such as hospitals? If you don't, you need to call your vendor today and ask them what they are doing in order to enable you to become fluent in data exchange so that you can promote yourself to the hospital. After you've done that, of course, you need to be looking at technologies such as home telehealth, technologies such as personal emergency response systems that you can provide to your patients that will keep them safer. Medication management systems, management of mismanagement is a huge reason for readmissions. Fall prevention programs, which I'm sure most of you have. Patient education systems so they understand their condition and how to take care of it themselves. Communication systems, which includes the telephone and the internet and devices in the home that allow them to contact you instead of calling 911. There is on the front that shows that you are actually getting better at using remote patient monitoring. It used to be stuck in the 17% range, and just last year, Fazzi Associates did a state of the industry study that showed that it's up to 28% of home care agencies are using telehealth. These are the 28% that are going to survive healthcare reform. You not only have to have all of these skills, but you have to be able to brag about them. You have to have the data printed in a format that you can hand to the hospitals and the ACOs and say, this is what we've been doing for the last 3 years. This demonstrates how good we are. Don't hide your light under a bushel basket, and you have to train your sales staff. This means, in my humble opinion, complete rewrite of the job description of your sales staff. You're not going to get anywhere anymore going from doctor to doctor to doctor with donuts saying, please, can we have a couple more referrals this month? You got to get your sales staff to make appointments in the C-suite of the hospital and the ACO and bring your CEO along for a high-level meeting and say, you want to partner with us because we are going to save you millions of dollars because we can reduce your readmissions. We can manage your patient's health before, during, and after admission. The pieces of information you need before you have that high-level meeting is what is the readmission penalty rate of the hospital that you're going to see. Fortunately, Kaiser Health News has printed it for you. You should write down this URL and look up your neighborhood. You can do it by state, by city, by zip code, and find all of the hospitals in your area, exactly what their readmission penalty is. So you look smart, go in for this C-level meeting and talk to them about promoting your service. Also, to attract partnerships with these organizations, there is a crisis going on that I need to talk to you about rather seriously. Is your clinical documentation accuracy and completeness and expertise a money maker? You turn on the tap and it brings you money, or is it money down the drain for you? Let me talk to you about your point of care system for a minute. The FOSSI State of the Industry study just this past year found that the point of care technology that you're using is not about increasing your profit margin. That's not what it's for. There are agencies with good and bad profit margins with and without point of care. It's how you use it. Point of care technology can be a means to improving efficiency, and profitability can be improved, but you improve it by improving your processes, not just by buying laptops for your nurses. That's what I found. That nearly 60% of the agencies using point of care have higher quality scores than the home health compare scores. What is clear is that quality scores can be increased by using point of care technology as long as it's accompanied by training, improved efficiency, and excellent support from your vendor. You can't just buy it and expect to. Let me ask you, where do your nurses complete their charts? In the presence of patients or here at the end of the day? The reason this is important is because human memory fails at a rapid rate. Studies have shown that when charts are completed at the end of the hours have gone by since you were in the presence of the patient, accuracy decreases. And when accuracy decreases, the studies have shown it costs you an average of $200 per PPS episode. If you allow your nurses to chart at the end of the day from memory, it is costing you thousands of dollars a month, hundreds of thousands of dollars a year, an average of $150 to $200 per episode. How do you fix this? Well, you can make it a rule. If you don't do it, I'm going to fire you. Or you can provide better tools. Maybe it's the software that you've chosen. Maybe it's just not possible for them to use it in the home because it's so slow. Maybe you need better software. Regardless of what software you're using, whatever you spend on training has a huge ROI. It comes back to you in improved payments per PPS episode. And by the way, not all of these work. I want to share them. The other thing that's a problem is when your clinical documentation is sloppy and incomplete and inaccurate, it makes you vulnerable to the heat team. It increases your likelihood of ADRs, payment denials, criminal accusations. You don't want these guys coming to your door and hauling out boxes of data. Because if you look very closely, as nice as these guys look, they're serious. They're very serious at what they're doing. You don't want to invite audits. You don't want to invite fraud accusations. But because the condition of clinical documentation today is so abysmal, the auditors are having a field day at payment denials. They can always find documentation flaws. The standard needs to be raised in home care, and it's training nurses that's at the core of what you have to do. What you have to do this is increased accuracy, which is going to give you $150 to $200 more per PPS episode. It's going to decrease your vulnerability to the ZPICs, the MACs, and reduce your number of ADRs. The right software actually improves the competency of your clinicians. Your patients get better care. Your employees are happier and stay with you longer. It saves you a ton of money to invest in improving the quality of your clinical documentation. So, one of the wisest men of the 20th century has one of the most important, I think, mottos that you could live by. In theory, there's no difference between theory and practice, but in practice, there's a big difference. So it's about your policies. It's about your concrete, what you do in practice. And let me wrap up with this because I think it's critically important. And then we'll go to your questions. What Fazzy found through a year of research is that 80% of you actually have on your books policies requiring clinicians to complete their documentation in the presence of the patient. That's a good thing. 80% of you have this policy. But then Fazzy gets some more detailed questions. How many of you have your nurses actually complying with that policy? The good ones, when more than 3/4 of the nurses are complying, just more than 1/4 of you said that your nurses are actually complying with it. Only half of you, a little more than half, are complying. 30% of you said that only half of your nurses comply with that rule. The ones that barely comply, 1/4 to 1/2 of you, a substantial 22%. And the ones that said, yeah, our nurses pretty much ignore that rule, an abysmal 19% of you said that. So having the policy on the books is not the answer. Training, 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 training. Encouragement, getting the right software. If you need to go through the pain and the expense of replacing your software, if your clinicians are telling you, I just can't do it in the home, this software is klutzy, it's slow, it doesn't think the way I think, then go through the expense of changing your software. Find something better. It will pay for itself in the long run. Remember, $100 to $200 per episode. What you have to do to improve the quality of your clinical documentation, making your agency less vulnerable to payment denials, increasing your payment per episode, is to get rid of those stupid 7-pound laptops. Get the lightweight devices. Move to a tablet or a 3-pound laptop with an all-day battery capacity. It should be able to connect with cell towers or Wi-Fi or both. It must be able to work when they are out of range of the cell tower, and they have to be able to document in the home where there is no cellular connectivity. And when they do return to connectivity and they have to synchronize, you cannot let them have one of these software systems that takes 30, 40, 50 minutes to synchronize the data. You've got to have a software vendor that has learned how to do this right. And ideally, if you can find it, you want software that teaches your clinicians to be better clinicians. A logical progress of assessment input to the care plan. The workflow has to go logically, and the assessment helps to build the care plan. When your software should improve your clinician's ability to do an accurate OASIS, not let them close it if it's incomplete. Look for logical inconsistencies. Let the software create a more accurate expert clinician. And of course, they don't like to type, especially on a tablet when they have to type on the screen. So find software that allows them to tap and click. This is what the clinicians are telling you they need in order to be able to complete the documentation in the patient's home. Lastly, consider the advantages of putting together post-acute care communities where you and your partners, hospice and palliative and home medical equipment, long-term rehab hospitals and group homes can all, with the nursing homes, can all go to the ACO together and say, discharge your patient to our network of care. Don't worry about our case managers and care transition managers will take care of where they go, making sure they go to the safest, least expensive care center as needed and as they're able. We will communicate with the physicians with you. We'll communicate with the hospitals. This is working extremely well, and I'm out of time, so I'll spare you the details, but working extremely well in Las Vegas, where a network just like this has brought the entire state of Nevada from 47th best as far as patient hospital readmissions to 24th best in 3 years by using these post-acute coordinated networks. Okay, I think that it's time for us to move into Q&A. I want to thank you very much for giving me your attention. I'm going to run to the last slide so that I can give you my contact information. I would be very happy to hear from you to offer you more details at any time.
Get there. That was fantastic. First, let me just say, wow, that was really amazing. If we could all give Tim a virtual high five or clap. Again, I'm always impressed by the speakers we have, but that's your presentation was very in particular interest to me. So thanks again for that very insightful and informative presentation. We very much appreciate it.
You're welcome.
Thank you. So yes, we do have some time for people to submit questions. So we're going to give you that time. Essentially, if you do have questions, you simply go to the chat panel in your GoToWebinar control panel, which should be roughly to the right of your screen. Also, if you're interested in sharing best practices as a webinar presenter, let us know. I know a lot of the people listening, a lot of the folks listening at home or at work, have other things to share as well, and we love to hear them. We're definitely passionate about healthcare in general and care transitions in specific. So anything you'd like to share, please let us know. Again, our next webinar will be next Wednesday, July 16th, at noon Eastern, 9 Pacific, as per usual. Also, I want to let you know that if you are interested in learning more about how to increase profitability via care transitions, we do have a bunch of resources on our website, including a white paper that's very simple to download and easy enough to go through. It's at www.ankota.com/care-transitions. You can see it on the screen, obviously, but also if you go to ankota.com, you can sort of navigate and see it there. And just real quick, just to give you a sense of things, just let you know a little bit about what Ankota is about as a company and sort of what we are, what we provide to the marketplace. We have software solutions that allow you to accept referrals from hospitals, assign care transition coach, schedule an episode, care transition documentation based on NTalk best practices. If you're not familiar with NTalk, check them out online. They're a fantastic organization. It runs on iPad or PC, and as Tim was mentioning, no internet connection needed at home. Includes billing and payroll calculation. It's fully HIPAA compliant, visibility to hospital, care team, and PCP. So it's a pretty all-encompassing solution to the care transition kind of conundrum. So yeah, if you have any questions in that regard, you can visit our website and contact us either via one of the easy forms we have. You can call us at 888-972-8190, or again, just connect with us online on our website. So let's see what we have. We actually do have a few questions. Tim, are you ready for me to fire them at you?
Absolutely.
Okay. We at Ankota believe that managing care transitions, avoiding 30-day readmissions, and partnering with ATOs to provide ongoing care that avoids admissions for the medically fragile is a big opportunity for home health, like telehealth. But we're so far finding a small percentage interested. So, two questions. One, do you think we're on the right track with this belief? And two, what do you think what do you think it will take to get care?
Well, um, I want to make sure I understand when you say a small percentage is interested. I'm assuming that means a small percentage of patients are interested in telehealth, or
No, I think
um,
the question is more along the lines of the agencies themselves.
a small percentage of agencies are interested in getting involved with telehealth.
Right.
You, you know, I feel for agencies today that are under so much pressure. The reimbursement rates are down. The paper and the idiotic face-to-face rulemaking is causing payment denials, and there's a great deal of pressure, and compliance is becoming more and more difficult. And so everyone is in a treading water mode. Everyone is basically focused on keeping the doors open and making payroll. So planning for spending more money to improve patient care is very low on the list. What I'm finding, though, is that the the changes that are coming to the entire U.S. healthcare system are changes that are forcing every care provider to focus on the patient experience, patient satisfaction, and patient outcomes, which requires patient self-care, and you accomplish that with um, training the patient and making sure they understand their condition. Today, the remote patient monitoring systems are uniquely aimed at accomplishing exactly those goals of, of providing two-way communication, educating the patient, making sure, you have a CHF patient who suddenly has a weight gain. You know about it the same day, and you can guide them toward dietary changes and temporary changes in their diuretics and the like. But the obstacles are serious ones. And one of the sections that I didn't have time to get to in my slide deck is that the telehealth vendors are changing to try to be more accommodating. More and more of them are offering rental programs. More and more of them are reducing the minimum number of units that they make you buy or rent in order to do business with them. So the first thing you do is look to some of the top vendors for their bargain basement arrangements and rentals and leases that you might be able to afford. If not, there is an alternative. There are a number of companies springing up that are warehousing the devices from the major vendors and then renting them to home care agencies. When they do this, you're looking at $100 a month per patient or somewhere in that neighborhood. And when the patient is discharged, you send the machine back to them. So you no longer are paying for it. The problem with minimums of telehealth devices is if you buy 50 of them, you're struggling to keep them off the shelf gathering dust. You're struggling to keep them in the patient home. With some of these alternative arrangements with some of these companies, you don't keep it. You send it back to them when the patient is discharged. So you never have excess equipment. Your costs go way down, and you have no capital upfront expense. You have only a monthly expense. So since I didn't get time to go to that slide, I would invite you to contact me if you would like to learn more about these other companies that are springing up that make this possible for you.
Yeah, I imagine a lot of the folks at home will, or folks at work will. Like once again, it was really your presentation was really quite amazing. So if you have time, we have a couple more questions. Like this one
Sure.
looks to be like a two-parter, and hopefully I won't stumble upon it the way I did the first one. So essentially, the next question is this: you sometimes refer to home care helping hospitals, and other times to helping accountable care organizations, but they aren't the same. Do you mean to say that both are have the same problem?
Well, it's an interesting phenomenon. What CMS is finding is that most of the ACOs are being organized and directed by physician groups, not by hospitals. And what everyone knows is happening is that physicians and even large physician groups and clinics are being are less and less independent and more employees of hospital systems. So what's happening is when the hospital sees the mandate to reduce readmissions, they extend that mandate to their employees. So these physician groups are being rewarded or punished by the hospital for their own role in increasing or decreasing 30-day readmissions. And as more and more of these physicians are involved with ACOs, the hospital is telling physicians in the ACO that they've got to shape up as well. So the ACO has its own list of 33 goals it has to accomplish from CMS. And it's also being instructed by the hospital that it works with or sometimes works for to control the readmissions. So it's becoming a group effort. It becomes um, everyone is focused on the same goal. So no matter whether you're talking to the hospital or the ACO, your ability to reduce readmissions is paramount.
Okay, this last one, I think we're kind of running out of time, so I'm going to ask this one last question, which may have been covered a little bit, but um, just because again, I'm more of a layman than a tech person, so I'd like to, refer to you. The question is this: home telehealth is still not reimbursed. How can we afford to purchase the equipment and offer it to our patients if we have to take the risk that it may or may not produce a return on investment?
Oh, if I had a nickel for every time I heard that question. Um, the the investment in telehealth eventually does pay off. Almost all of the studies show it. Almost all of the agencies that I talk to are finding that the ability to monitor patient vitals every day provides such a profound competitive advantage that it eventually leads toward growth. And growth is the key to survival these days. As these little mom and pop agencies disappear because they can't maintain a profit margin anymore, competition among the survivors is going to get more and more severe. And if you're an ACO looking for a partner that's going to keep your costs down and help you to meet the goals that CMS has mandated for you, who are you going to partner with? Are you going to partner with a technologically sophisticated home care provider, or are you going to partner with one that is still living in the last decade and has not invested in these technologies? Um, and if you're not the agency in town that partners with the ACO, where are you going to get your referrals from? This is the question that everyone needs to ask themselves. I'll give you an example of a story that happened a year ago when an ACO opened up here in Colorado. They interviewed and decided to partner with 4 home health care agencies out of 100 that they had access to. Those others that don't have access to the patients that belong to the ACO are going to be struggling and very likely not surviving. So my advice to you is sell the Lexus and buy home telehealth systems.
Well, that was Summed it up pretty well, I have to say. So listen, we're actually perfectly on time. Once again, not to, to give you too much props, but it was really a pleasure to have you on. And thanks again to all of our listeners and viewers at home. I keep on saying that. I feel like I'm a, Ed Sullivan or something. But all the people listening at their computers, thank you so much. Again, once again, we're here every month. And if you do have any questions, please feel free to contact Tim, myself, or just the Ankota website in general. Tim, once again, thank you. And with that, I will bid you adieu until next month.
Thanks, Jed, and thanks everyone at Ankota, and thank you all for listening. I enjoyed it, and I would be happy to hear from you at any time.
All right, great. Thanks again. Have a great day, everybody.